Hello friends, today let's discuss about Alport syndrome and other familial glomerular disorders. So this topic will be dealt under the following headings. First we'll see what is Alport syndrome. Under Alport syndrome we'll go under these headings, that is etiopathogenesis, genetics, what are the features, what is the renal pathology in Alport syndrome, what is the treatment. Then other familial glomerular disorders, that is Hannack syndrome, thin basement membrane nephropathy, Fabry disease, Neil-Patella syndrome, and finally we'll end with high yield points. This high yield points is a revision capsule which contains questions which have been asked as MCQ previously. And when it comes to exam point of view, I can tell you this chapter is a gold mine. That is, many questions are going to come from this chapter because it has a lot of fancy names which you will be seeing. Now, Alport syndrome. Okay. Alport syndrome is a disorder of glomerular basement membrane. So we are learning the familial glomerular disorders, right? So in the glomerular disorders, Alport syndrome generally is a problem of the glomerular basement membrane. So which component of the glomerular basement membrane? Generally it affects the type 4 collagen. See, generally we know that there are 5 types of collagen that is distributed in different things like skin, cartilage and other tissues. In kidney, in the glomerular basement membrane, the predominant collagen is collagen type 4. This is a disease which has major features of hematuria, progressive deafness, nephropathy and also ocular abnormalities. So mainly eye involvement, ear involvement and also kidney involvement. These are the main things that are seen in Alport syndrome. Eye plus ear plus kidney, right? Now, coming to the etiopathogenesis. Etiopathogenesis, I have told that type 4 is the type of collagen that is present in the glomerular basement membrane. So, each collagen is made up of alpha chains. Okay, how many alpha chains? That is 3 alpha chains. Generally, there are 6 types of alpha chains, that is alpha chains can be alpha 1, alpha 2, alpha 3, alpha 4, alpha 5 and alpha 6, right? Now this type of collagen is present in the basement membrane. Earlier when I told you it is mostly disease of the glomerular basement membrane, I was just telling the kidney part of it, but it can involve basement membrane of the ear, of the eye also. That is how it affects the other organs also. So this is type 4 collagen of the basement membrane in kidney, glomerular basement membrane. I hope that is clear. So there are basically 6 alpha chains, that is alpha 1 to alpha 6, and 3 of these alpha chains form together to form a type of type 4 collagen which is going to get deposited in the basement membrane. So these alpha chains are made up of triple amino acid residues, that is glycine X, Y. So these triple sequence keeps getting repeated. Okay. So there are 3 types of type 4 collagen heterotrimer, that is 3 types of collagen are available. Either it can be alpha 1, 2, that is alpha 1 and alpha 2, or it can be alpha 3, alpha 4, alpha 5, or it can be alpha 5 and alpha 6. This is not very important to remember. You just have to know that there will be a type 4 collagen. Type 4 collagen is formed of alpha chains, 3 alpha chains. There are 6 types of alpha chain, and in the 3 alpha chain it is formed by glycine X, Y triple amino acid repeat sequences, right? Now, this picture demonstrates what I just told. See, this is the gene, that is Col4A1. Okay, that is collagen type 4. In that, the alpha 1 chain. So this gene will produce the alpha 1 chain. This Col4A2 produces the alpha 2. This is there in chromosome 13. So this gene is there in chromosome 13. Similarly, Col4A3 produces the alpha 3. Col4A4 produces the alpha 4. This is present in chromosome 2. Col4A5 produces alpha 5. Col4A6 produces alpha 6. So this is present in chromosome X. So there can be different types. There can be X-linked inheritance also. There can be autosomal inheritance also. Okay, because of the different locations of these genes, right? So this is the type 4 collagen chain. This is showing a single alpha chain which has a glycine XY repeat, and then there is this type 4 collagen molecule which is formed as a 3 alpha chains, 1, 2 and 3. 3 alpha chains are coming together and it is coiling around and forming a type 4 collagen molecule, right? So what does it mean? Even in this, if 1 is not present, then the type 4 collagen molecule cannot get formed. So this is what you have to understand, the basics of the glomerular basement membrane or any basement membrane and how the disease happens. Now, etiopathogenesis, we told that these type 4 collagen is present in basement membrane. So, these are the different places where basement membranes are present. In glomerular basement membrane, it is alpha 1 and alpha 2 chains deposited and alpha 3, alpha 4 and alpha 5, right? In the epidermal basement membrane, the chains are alpha 1 and alpha 2, alpha 5 and alpha 6. Okay. In the Bowman capsule, it is alpha 3, alpha 4 and alpha 5. In the distal tubule of the kidney also, it is the same. And similarly, like that, in the alveolar basement membrane and in the testis, eye and ear also, it is the same. So, alpha 3, alpha 4, alpha 5. Here also you can see in the kidney and in all other structures, alpha 3, alpha 4, alpha 5 are common. Only in the epidermal basement membrane, you have alpha 6 also coming in. Right. So, why should you know this table? As the chapter goes on, you will understand why I have told that this table is important. Okay. Just remember that alpha 3, alpha 4, alpha 5 is the main component of collagen 4 in basement membrane. Now, what are the genetic inheritances of Alport syndrome? Like we saw in this diagram, it can be autosomal inheritance or it can be X-linked inheritance, right? Because of the presence of the gene in X chromosome and in autosomal chromosomes. Now, if it is X-linked inheritance, there can be two types. It can be plain X-linked Alport syndrome or it can be X-linked Alport syndrome with leiomyomatosis. Okay. So, this is in Col4A5 is the affected locus. That is alpha 5 is the gene product. If both 5 and 6 are affected, which is there in the X chromosome, then it will cause deficiency of alpha 5 and alpha 6. So, this is X-linked disease. Next is autosomal recessive. Autosomal recessive generally involves alpha 3 and alpha 4, Col4A3 and Col4A4 gene, which will cause alpha 3 and alpha 4 deficiency. Autosomal dominant also has Col4A3, Col4A4 mutation, which causes deficiency of alpha 3 and alpha 4. So, the types of inheritance is X-linked and is autosomal. In X-linked, there are two types, plain X-linked and X-linked associated with leiomyomatosis. And in autosomal, there are two types, that is autosomal dominant and autosomal recessive, right? Now, what are the different manifestations of these different types of disease? X-linked is the most common type with around 80% incidence, okay? Generally, missense mutations are more severe than splice site mutations, okay, severe manifestation. Males are symptomatic like any other X-linked disease. Males are symptomatic and more affected because they have only one X sex chromosome. So, they are going to be more severely affected and they reach ESRD, that is end stage renal disease, by 30 years. In females, there is much variability of presentation, okay, and ESRD, if at all occurring, occurs much later in much lesser number of people. So, this is about X-linked. The next severe form is autosomal recessive Alport syndrome. It is seen in around 15% of patients. Here, if a patient comes to us clinically looking like Alport syndrome, but there is no family history, because in the parental lineage, it will be a recessive inheritance, right? Recessive gene. So, it couldn't have presented. So, if there is no family history and if there is no gender differences because it is not in the X chromosome, then we should think about autosomal recessive Alport syndrome. And here it is a severe form. ESRD and deafness generally occurs by less than 30 years, like in the male of X-linked Alport syndrome. Next is autosomal dominant Alport syndrome. It is generally seen in 5% of the patients. Recently, studies are showing that it is seen more than 5%, around 10 to 15%. But this is the most asymptomatic form. There is asymptomatic hematuria and only some patients have progressive nephropathy. So, a very safe form is autosomal dominant type of Alport syndrome, where ESRD is very, very rare. So, most common is X-linked Alport syndrome, and X-linked Alport syndrome and autosomal recessive Alport syndrome both are capable to cause severe renal disease. Okay. Now, this is the chart which shows what are the types of collagen that is present in each patient of Alport syndrome, right? So, normally we saw in that chart that in the different basement membranes that were present, and alpha 3, alpha 4, alpha 5 being present in almost all basement membrane. And in epidermal basement membrane, it is alpha 5 and alpha 6, right? So, first see this part of the table. Here it is collagen group they are telling. Okay. So, they have divided into 4 groups. First is normal. Second is X-linked males. Third is X-linked females because there is significant difference in the presentation. Fourth is autosomal recessive types, both males and females. So, in normal, and they have seen it across four basement membrane: glomerular basement membrane, Bowman's capsule, distal tubule, and epidermal basement membrane. Now, I would like you to concentrate on glomerular basement membrane and epidermal basement membrane. Okay, this is very, very important. Now, in normal, alpha 3, alpha 4, alpha 5 is present in glomerular basement membrane, in the Bowman capsule, in the distal tubular membrane, but in epidermal basement membrane, you remember what I told, alpha 3, alpha 4, alpha 5 is not there, only alpha 5 and alpha 6 is there. So, what happens? Alpha 3 and alpha 4 are naturally absent and only alpha 6 is present. Clear? This is about normal people. Now, what happens in X-linked Alport syndrome? We know that it is called for A5 mutation, right? So, that is alpha 5 is lost. What happens in X-linked Alport syndrome is because of the severity of mutation, alpha 5 is not at all present and hence collagen cannot form at all. So, if this type of collagen will form only if alpha 3, alpha 4, alpha 5, all 3 are coming together. Even if one is missing, then the three alpha chains coming together if the 3 alpha chain coming together is not there, then these two will disintegrate and then the type of collagen is not formed at all. Okay. So, glomerular basement membrane, all 3 are absent. In Bowman's capsule, all 3 are absent. In distal tubular basement membrane, all 3 are absent, and also in epidermal basement membrane, alpha 5 is absent, right? So, when you do a biopsy of the skin or if you do a biopsy of the kidney, you will not be able to stain for any of these stains in X-linked male. Now, in X-linked female, generally it is mosaic pattern, that is some amount of alpha 5 can be there. Assume it is like this, some amount of alpha 5 can be there. So, some amount of mosaicism is seen, that is triple helix will be seen with these 3 chains. Okay. Now, here again in the basement membrane you will see mosaic, but in the epidermal basement membrane some amount of alpha 5 will be present. So, mosaic pattern can be seen there, right? Next, coming to the autosomal recessive type of Alport syndrome. In autosomal recessive type, all these 3 are absent, that is alpha 3, alpha 4, alpha 5, all 3 are absent in the glomerular basement membrane. In the Bowman's, in the autosomal recessive, which are the chains that are involved? We know that call for A3 and call for A4, that is alpha 3, alpha 4 is affected, right? So, what is going to happen? In the glomerular basement membrane, like I told you, all 3 has to come together. So, if one is absent, the entire thing is gone. So, it is all 3 are absent in glomerular basement membrane, but in the epidermal basement membrane, the alpha 5 chain is going to be present, right? So, this is important because this is by immunohistochemistry you can stain these chains, and immunohistochemistry can be used to differentiate between a X-linked Alport syndrome and a autosomal recessive Alport syndrome, because here in skin biopsy you are going to stain and find alpha 5 chain in case of autosomal recessive Alport syndrome, but you will not find that chain in case of X-linked Alport syndrome. So, this is why this table is important. Now, like I told, X-linked Alport syndrome and autosomal recessive Alport syndrome can be differentiated by immunohistochemistry, because this is nothing but immunohistochemistry. So, staining will clearly tell us which is what. Now, basement membrane expression of collagen chain is normal in autosomal dominant Alport syndrome. till now we saw in X-linked autosomal recessive, all these changes can happen, but in autosomal dominant Alport syndrome, it is completely normal. There will be no change in staining. So there is no point in biopsying or staining these patients. Okay. Now, what are the clinical features? Hematuria is the cardinal finding. See, Alport syndrome, the most important or cardinal feature is hematuria, not proteinuria. It's easy to get confused because if question comes as what is the cardinal finding of Alport syndrome, it is hematuria and it is not proteinuria. Okay. So there can be persistent microhematuria in males. So in males, it starts pretty early. There is going to be always some RBCs in the urine. In females with X-linked Alport syndrome, more than 90% are microhematuria, but doesn't mean that they are going to progress much. Okay. Episodic macrohematuria can generally be seen in the first 2 decades of life itself. And by 10 years, if the patient is free of hematuria, patient is unlikely to be affected. So, for example, if there is a sibling and we want to know whether the sibling is affected, and by 10 years, if the child does not have hematuria, then you can almost rule out that this patient could have had Alport syndrome, because hematuria is one of the first features and it starts pretty early. Okay, so hematuria can be both micro and macro. Micro is generally persistent, starts at childhood or in a very, very young age, maybe less than 1 to 2 years also, and it continues to be persisting. And macrohematuria generally appears in the first 2 decades of life. Proteinuria is absent early in the disease, okay, and slowly it increases later, causing nephrotic syndrome. And it is seen in all males of X-linked Alport syndrome and both sex in autosomal recessive Alport syndrome, where there is no difference, no sex difference between these two groups. Now, coming to renal defects that can be seen in these patients. ESRD. All males with X-linked Alport syndrome develop ESRD. Okay, so that is a big thing to tell. All males with X-linked Alport syndrome, that is 100% of patients develop ESRD, out of which 90% develop less than 40 years of age. So it is a very, very progressive disease. It is generally, if patient has X-linked AS, then patient will develop ESRD. So intra-family progression rate is same. For example, if one brother developed ESRD at 40 years, then second brother also developing ESRD at that age is common. Okay, so more than 90% of them develop by 40 years. In females with X-linked Alport syndrome, generally lesser number only develop by 40 years. See, there 90% males 90% develop by 40 years, but here only 12%. In males 90% developed by 40 years, right? But in females only 10% developed. It's not important to remember these numbers. I just put it to show the importance that there is significant difference between the males and females of X-linked Alport syndrome. Okay. In autosomal recessive, both sex develop ESRD by second or third decade. Okay, both male and female will develop, irrespective of sex, they develop ESRD by second or third decade. Now, these are the renal defects. Now, coming to the cochlear defects. Cochlear defect or hearing impairment is almost always associated with renal impairment. So, if kidney is affected, ear is also affected. But early stages, there will be no hearing defect. It is somewhere frequencies around 2000 Hz. So, it can be picked up only by audiometry. Okay. And hearing loss is never congenital. It's very important to remember this point. So they can ask all of these are true about Alport syndrome except, and one of the options can be hearing loss occurs at birth or is congenital. So it's never congenital and it comes only by late childhood. Okay. So more than 90% of males and 25 to 30% of females of X-linked Alport syndrome develop this. So in X-linked Alport syndrome, more than 90% became ESRD by 40 years, right? And all had renal disease. So of course, if all patients with renal disease will have ear disease, so ear disease is also seen in more than 90% of patients, but significantly lesser in females, right? And generally it is by 40 years, 90% developed by 40 years of age. Okay. In autosomal recessive Alport syndrome, around 40 to 65% of them develop deafness. Next, coming to the ocular defects. Okay, there are 4 important ocular defects that we have to know. So it is mostly seen in 30 to 40% of males with X-linked AS and only 15% of females. Okay, and in autosomal dominant it is never seen. So kidney lesion is seen in almost 100% of patients. I am talking only about males with X-linked Alport syndrome, and hearing loss is seen in around 90% of patients, and eye defects are seen in around 30 to 40%. So eye defects is significantly lesser in number, right? In autosomal dominant, it is never seen. There are 4 important ocular findings that is seen in Alport syndrome. First is anterior lenticonus. This anterior lenticonus is pathognomic. See, as of now, we have dealt with 2 things. One is cardinal. What is the cardinal feature of Alport syndrome? It is hematuria. And if the question is what is pathognomic of Alport syndrome, it is anterior lenticonus, right? So the presence of anterior lenticonus indicates that ESRD is going to occur by 30 years and patient is also going to have deafness. It generally appears by 2nd or 3rd decade after the onset of CKD, and it is bilateral in 75% of people. Okay, so pathognomic lesion of Alport syndrome is anterior lenticonus. Next is maculopathy. These are nothing but whitish or yellowish flecks of granulations that are present in the perimacular area, not causing any visual abnormalities. Lenticonus can cause visual abnormalities, but maculopathy does not cause any visual abnormality. Third is corneal endothelial vesicles, or it's also called as posterior polymorphous dystrophy. Okay, so there are going to be defects in the Descemet's membrane. There are going to be endothelial vesicles, so it's called as posterior polymorphous dystrophy or corneal endothelial vesicle. Fourth is recurrent corneal abrasion can happen because of these corneal defects. So these are the 4 important ocular manifestations of Alport syndrome, out of which pathognomic is anterior lenticonus. Now Next, coming to leiomyomatosis. We know that if alpha 5 and alpha 6 is combined together, then it causes Alport syndrome with leiomyomatosis. So that means leiomyomas are going to be seen where in the esophagus, in the tracheobronchial tree, and also in the genital area. Patients can generally also have bilateral posterior subcapsular cataract. So see, in the Alport syndrome, per se, we are not seeing cataract. We saw lenticonus, we saw maculopathy, we saw posterior polymorphous dystrophy, and we saw corneal vesicle. But here we are seeing cataract. If they ask, all of the following are manifestations of Alport syndrome, except, then the answer should be cataract. If cataract is involved in one of the options, because it is seen in Alport syndrome plus leiomyomatosis. Okay, symptoms are generally seen in the late childhood. Now, coming to few hematological defects. These cannot be called as hematological defects happening in Alport syndrome. These are diseases that mimic Alport syndrome, that is mutations in MYH9 gene diseases that can mimic Alport syndrome, and they can have these abnormalities. That is, first is Epstein syndrome. That is, it has 3 important components, that is hereditary nephritis, deafness, and instead of ocular abnormality, they have megathrombocytopenia, right? The second syndrome is Fechner syndrome, who has the same. They have hereditary nephritis, deafness, and instead of ocular, hematological, that is megathrombocytopenia, and May-Heglin anomaly, which is a leukocyte inclusion body, So, these are mimickers of Alport syndrome. But if patient looks like Alport syndrome, that is, patient has deafness, patient has renal failure, but along with that patient has these hematological abnormality, which can be megathrombocytopenia or this May-Heglin anomaly, which is leukocyte inclusion, then it is wiser to think in terms of diseases causing mutations in MYH9. Now, renal pathology, light microscopy, generally less than 5 years, there are no changes. Later also, mesangial hypercellularity and some matrix expansion can be seen. It is not very much evident in light microscopy. Generally, once 10 years crosses, features of chronicity like FSGS or interstitial fibrosis and tubular atrophy will be seen. Immunofluorescence can be used to identify the type of collagen chain. Immunofluorescence or immunohistochemistry can be used to the type of collagen chain, like I showed previously in that table. Now, electron microscopy. Electron microscopy can show various features. There can be thinning, there can be thickening. Thickening can generally extend up to 1200 nanometer. There can be basket weaving and lamination of GBM. This was asked as an MCQ. See, so this basement membrane is variable. It can be thin, it can be thick, and there can be weaving sort of a pattern in the GBM, that is called as basket weaving, or there can be lamination. So all these are the features that can occur in Alport syndrome, electron microscopy. Round granules can be seen in the electrolucent areas of lamina densa. Lamina densa is a part of glomerular basement membrane where round granules can be seen, and fusion of food processes can be seen if the patient is going into FSGS and renal failure. Okay, so when a patient comes to us with renal failure, how do we suspect and evaluate Alport syndrome? First is patient, if he has no proteinuria or no family history of ESRD, okay, and patient has hearing defects, okay, then we have to go ahead and do audiogram. Ophthalmic examination might not give much because remember what I told, only in 30 to 40% of patients you are going to find eye defect, but hearing defect and ESRD almost go hand in hand. If this is there, this is also going to be there. So you can go ahead and do this thing, and mostly it is going to be autosomal recessive form if there is no family history. That means in that situations also ocular defects coming out is very rare, right? So there is no point in doing ophthalmic examination. So skin biopsy can be done to see the type of alpha chain. So we'll type for alpha 5 and alpha 6 chain. So if it is normal, then it is something called as thin basement membrane nephropathy. I'll be coming to this next. What is thin basement membrane nephropathy? If it is abnormal, then it is diagnostic of X-linked Alport syndrome. Okay, that is if the alpha 5 is deficient, then it is diagnostic of X-linked alpha syndrome, X-linked Alport syndrome. The type of collagen or alpha chain that is present in basement membrane is glomerular basement membrane is alpha 3, alpha 4, alpha 5, and epidermal basement membrane is alpha 5, alpha 6. So alpha 5 is common for both. So here if it is absent, alpha 5 is absent, then it is diagnostic of X-linked Alport syndrome. Then kidney biopsy is often unnecessary, and molecular genetics also is unnecessary, because if alpha 5 is absent and patient has deafness and CKD, it is Alport syndrome. Okay. Now patient has no proteinuria, but patient has family history of ESRD. Okay. In this situation, audiogram will definitely be helpful. Ophthalmic examination also may be helpful, because more is the chance of, if there is ESRD, more is the chance of eye finding coming. Okay. Then skin biopsy has to be done. If skin biopsy is abnormal, it is diagnostic of X-linked Alport syndrome. That is the same thing if alpha 5 is absent. But if it is normal also, it does not rule out autosomal types. Okay, that is, if alpha 5 is present also, it will not rule out autosomal types, because alpha 3, alpha 4 is what is seen. Right. So in this situation, it is sometimes required to go ahead and do kidney biopsy, because in kidney all three chains are present, that is alpha 3, alpha 4 and alpha 5 has to be done. Okay. And molecular genetics also may be helpful when full clinical and tissue evaluation fails to provide firm diagnosis or identify genetic types of Alport syndrome. Okay. Now, if there is proteinuria, family history of hematuria or ESRD, it is a same chart. Here, if the family history of ESRD is not there and just hematuria is there also, we proceed with the same thing. That is, first we do a audiogram, then we do ophthalmic examination, then we go ahead and do skin biopsy. But if skin biopsy is normal, then kidney biopsy will have to be done with or without molecular genetics. So this is the approach for a patient who comes with a familial nephropathy along with deafness and ophthalmic or eye involvement. Now, how do we treat this condition? Early screening for hematuria for at-risk children has to be done. For example, we know that the sibling has, or if parents have, then it has to be done. Early introduction of renin-angiotensin system blockers to reduce the proteinuria. Okay, if the proteinuria is between 0.2 to 1 milligram by milligram, reduce proteinuria by 50%. But if it is more than 2 milligram by milligram, then it is wise to reduce the proteinuria to less than 0.5 milligram by milligram. So, in this situation, you are not going to in this situation, you are going to avoid proteinuria from worsening the renal function. Okay, so only problem with transplant is this, whatever, for example, if you take X-linked Alport syndrome, the alpha 5 chain which is going to be there in the donor's kidney is going to be new to the recipient. So recipient is going to produce anti-alpha 5 antibody. So this is going to bind to the GBM and it is going to cause anti-GBM disease. So in this situation, if patient is going to have a biopsy picture post-transplant showing anti-GBM disease, it is important to know that anti-GBM antibody may be negative and patient is going to have anti-alpha 5 antibody, right? So this is what is with the treatment plan of Alport syndrome. Next, coming to the syndrome called HANAC syndrome. It is an autosomal dominant syndrome. HANAC stands for, HA stands for hereditary angiopathy. So hereditary angiopathy means there is going to be intracranial aneurysms, there is going to be retinal aneurysm. The next is nephropathy. Nephropathy, NN, right? Nephropathy. So nephropathy is basically patient is going to have microhematuria and patient is going to have cyst. Next is aneurysm. Aneurysms can exist in various vessels, and C stands for cramps, okay, muscle cramps. This is not very important exam point of view, but still it is better to know the expansion of HANAC syndrome, which is hereditary angiopathy, nephropathy, aneurysm and cramps. Okay, electron microscopy shows basement membrane splitting and multilayering, and the presentation and treatment is going to be same like Alport syndrome, right? I mean, the reaching of ESRD and treatment is going to be same as Alport syndrome. Now let's come to thin basement membrane nephropathy. That means what? Here the problem is just thinning of the basement membrane. Okay, it is familial or sporadic type which shows attenuated glomerular basement membrane and patient presents with isolated hematuria. Okay, mostly microhematuria. So there will be thinning of GBM. RBCs are freely let into the GBM and hence patient can present with microhematuria. Okay, now what is the difference between thin basement membrane nephropathy and Alport syndrome? Because both can have microhematuria. In thin basement membrane nephropathy, extrarenal manifestations are rare because in Alport syndrome, there was deafness, there was eye defects, all these things are going to be rare. Okay, and proteinuria, hypertension and progression to ESRD is rare. It is less than 10% and it is unusual before the age of 40 years. See, there in Alport syndrome, we learned that 90% of them go into ESRD by 40 years. Here, going into ESRD itself is rare, that is less than 10%, and it is highly unusual for it to occur in less than 40 years, and no gender difference is seen, unlike in Alport syndrome, X-linked Alport syndrome, where male had more severe manifestation than female. And here transmission is autosomal dominant in the sporadic transmission is autosomal dominant in the familial form. Okay, now etiology, it is because of a different type of mutation in COL4A3 and A4, which does not cause Alport syndrome, but it just causes microhematuria. Okay, so immunohistologic studies when done shows normal 6 alpha chains. Okay, so if at all there is a confusion, a young male or a male child comes with microhematuria, and of course we know that the hearing defects and the ocular defects starts only in the late childhood. Okay, so if we want to differentiate between Alport syndrome and thin basement membrane nephropathy in this patient, because the spectrum is completely opposite, right? One patient can lose his or her kidney by 40 years. The other one is going to be just fine. So it's important to differentiate this. So in this situation, immunohistochemistry can be done. So immunohistochemistry in thin basement membrane nephropathy is going to be normal. That is, the skin biopsy is going to show the alpha 5 chain, which is positive. But in Alport syndrome, it is going to be deficient. Alpha chains are going to be absent. Okay. Now, Clinical features of thin basement membrane nephropathy. It is the most common cause of persistent microhematuria. Okay, intermittent macrohematuria also can occur. Proteinuria and hypertension is seen in 30% of adults. ESRD is seen in less than 10% of adults. Okay, so proteinuria and hypertension can occur in 30%. Now coming to the renal pathology. Biopsy shows atypical features, mostly light microscopy and immunofluorescence are normal, and in electron microscopy the only thing that is going to help us is the thin basement membrane. So how do we define thin basement membrane? It is by the size of the basement membrane. So for that we should know what is normal. Normal in adult male is approximately 373 plus or minus 42 nanometer, and in women is 326 plus or minus 45. So somewhere it can range between 300 to 400 nanometer normally. Okay, so if the thinning of the glomerular basement membrane is less than 250 nanometer, then we call it as thin basement membrane nephropathy. And if there is variability, that is, we discussed the 4 points, right? Thinning, thickening, basket weaving and lamination. If these 4 things are present, then it is suggestive of Alport syndrome. In thin basement membrane, it is just thin. It is plainly thin and it is less than 250 nanometer. In Alport syndrome, there will be thickening, then there will be thinning, then there will be basket weaving and lamination. All these can be seen in glomerular basement membrane of Alport syndrome patient. Now, treatment is, follow-up is to be done generally once a year for these patients, and when they're coming back, it's important to measure their blood pressure, their urinary protein, and whether how much is their creatinine. Renal failure is seen in less than 5 to 10% of the patients. Okay. Now, so this is a simple condition, unlike the very dreadful Alport syndrome, but it stays in the same spectrum where there is hematuria there, but there is unlikely the disease will progress, but in that the disease generally progresses. Next, coming to Fabry's disease. Fabry disease is hereditary deficiency of galactosidase A enzyme. So when the galactosidase A enzyme is deficient, there is going to be intracellular accumulation of glycosphingolipids. So this can lead to progressive CKD, there can be pain crisis, sweating abnormalities, vascular cutaneous lesions, cardiac and eye abnormality. As we go on, you will see which are all these abnormalities. Now, etiopathogenesis. The gene is alpha gal A gene. Okay, alpha gal A gene. This is present on the X chromosome. So this codes for alpha galactosidase that is involved in the breaking of glycosphingolipids. So in this condition, what happens is glycosphingolipids are going to accumulate, and these are normal constants of cell membranes and organelles. Okay, so in all tissues it accumulates except in RBC. Now, clinical features. Clinical features involve mainly kidney, heart and brain. Like how Alport syndrome involved kidney, eyes and ears. These 3 are the organs that are mainly involved in Fabry's disease. In brain, it can involve the central nervous system and the peripheral nervous system. Okay. Here also, since it is an X-linked disease, it is severity is more in hemizygous males. Okay. The episode generally starts in childhood. First manifestation is going to be, there is going to be pain crisis and paresthesias. ESRD generally occurs later, that is at 3rd to 6th decade. The terminal event is going to be myocardial ischemia or cerebral ischemias, okay, or cerebral infarctions. These are going to be the terminal events. Now, what are the renal manifestation? The first defect that is going to be seen is renal concentrating defect. It generally starts in the 3rd decade. Patient is going to have mild to moderate proteinuria and also hematuria like any other glomerular disease. The diagnosis of this condition is by something called as urinary fat bodies presenting as Maltese cross appearance. So this Maltese cross appearance, this is a type of appearance of fat globules that is seen in the urine, that is seen in polarizing microscopy. Okay, and also the glomerular epithelial cell shows glycosphingolipids. This accumulation majorly happens in the visceral epithelial cell, in the lysosome of the visceral epithelial cell. So their zebra bodies can be seen, which are nothing but in the lysosome there is layers of dense material, which are these glycosphingolipids, that is separated by clear spaces. So zebra bodies can be seen. Zebra bodies can be seen where? In the lysosome of the visceral epithelial cell of the podocyte. Epithelial cell of podocyte. Okay, so this is zebra body. So we learned two important names. One is urinary oval fat bodies, which will show Maltese cross appearance. That is the urine finding. Other finding is in the biopsy electron microscopy, that is zebra bodies. Okay, detachment of the visceral epithelial cell from the basement membrane also can be seen, and FSGS can be seen. Now, heart involvement, coronary artery disease can be seen because of glycosphingolipid accumulation can happen in the coronaries, and arrhythmias can be seen because of the infiltration of the conducting system of the heart. So these two are the heart manifestations. Now left is the nervous system. There can be autonomic dysfunction, that is hypohidrosis or acral paresthesias, pain, altered intestinal motility, all this can be seen. In the cerebrovascular system, it can deposit in the vertebrobasilar artery and cause symptoms like TIA, strokes. It can cause dysarthrias, dysphagias, and it is generally seen in the fourth decade. So what you have to remember is one of the first presentations are pain and paresthesias. Okay, and generally the terminal events are strokes and MIs. Okay. Now, in the skin there is lesion called angiokeratoma, which generally appears in the second decade of the life. So these are nothing but, here you can see, this is a picture that is taken from the Fihalis textbook. So here you can see that there are dark red macules or papules that are seen of variable size, and it can be generally seen in the lower trunks, in the buttocks, in the hips, genitalia, and in the upper thighs. Okay, so it is generally seen in the lower trunk and below. In the histology, there is a dilated vein covered by hyperkeratotic dermis. Okay, so now, what are the other manifestations that are seen? Corneal opacity can be seen, that is verticillata. What is verticillata? Whorls of whitish opacity that are radiating from the center of cornea. So, this is called as verticillata. It is generally seen in 75% of the patients. Cataracts also can be seen, and obstructive airway disease. So, see, though I told that kidney, heart and brain are the important organs involved, in Fabry's disease, skin and eye also can be involved. In skin, you saw angiokeratoma, and in cornea you saw verticillata. Okay, so these are the two things, right? Now, this is about Fabry syndrome. Now, next coming to nail patella syndrome. Nail patella syndrome, it is autosomal dominant. Fabry was X-linked disease. Nail patella is autosomal dominant. So, what and all, there is, the name itself says that there is going to be nail problem and patellar problem. So, what are the patellar problem? There is going to be hypoplasia or absent patella. Okay, the nails are going to be dystrophic. Along with that, of course, if I am discussing this in nephrology, that means kidney problem also will be there, renal disease, and there is going to be dysplasia of the elbow and the iliac horns. Okay, now generally it is because of the involvement of a gene called LMX1B gene, which is involved in the development of the patella and of the kidney. Now, renal defects in this nail patella syndrome is generally benign. It occurs in less than 50% of patients. Okay, generally nephropathy happens and it progresses to ESRD in 3 to 5% of patients only. Kidney disease is seen in 50%, but ESRD, that is end stage dialysis requiring or transplant requiring, is seen in only 5% of patients. Generally, microhematuria or proteinuria occurs, which progresses to nephrotic syndrome. What happens in renal pathology? Renal pathology, in light microscopy, there is going to be mild mesangial hypercellularity and there is going to be FSGS, which is the terminal event in any glomerular disease that is going into CKD. In the electron microscopy, there is going to be moth-eaten appearance. Okay, so this is the picture. This is the glomerular basement membrane. I hope you can see this electrolucencies. This is what is the moth-eaten appearance that is seen in the glomerular basement membrane. These lucent areas are nothing but the cross-banded type 3 collagen fibrils that are present, that have been stained with phosphotungstic acid. So these are the type 3 collagen fibrils that are present. Okay, so if this is an important MCQ. They ask moth-eaten appearance of the glomerular basement membrane is seen in which disease? It is nail patella syndrome. Okay. Now, what are the skeletal defects? In the knee joint, patella will be absent and knee joint effusion will be seen. In the iliac horns, the osseous process project posteriorly from the iliac wings. Okay. So, in this picture here, you can see that patella is absent in this condition. And here from the iliac wings, you can see these projections. Okay, so these projections, these are pathognomic conditions and it is called as iliac horns. Okay, so this is pathognomic, and elbow also there can be aplasia and hypoplasia. Nail abnormalities are generally bilateral and symmetric. Fingernail abnormality is more than toenail abnormality. Fingernail, generally there will be dystrophia with discoloration. There can be koilonychia or there can be longitudinal ridges, which are the nail defects that can be seen in this condition. There is no specific treatment. If at all this patient goes into ESRD and requires a transplant also, there is no recurrence in transplant. The chance of going into ESRD is very, very less. If proteinuria is occurring in these patients, ACE inhibitors or angiotensin receptor blockers and antihypertensives can be considered. Okay. So, coming to the high yield questions, like I told you, this chapter is a gold mine when it comes to MCQs. Definitely 1 or 2 questions will be asked from this chapter. So, the type of collagen chain in GBM, the significant type is type 4 collagen. The alpha chains in the GBM, we learned there are 2 types of alpha 1, alpha 2 and alpha 3, alpha 4, alpha 5. So, these are the chains that are present in the GBM. What are the types of inheritance in Alport syndrome? We know that there is X-linked, which had 2 types, which is X-linked, plain X-linked Alport syndrome and X-linked Alport syndrome with leiomyomatosis, which is seen in around 80% of patients. Next was autosomal recessive type of Alport syndrome, which is seen in 15% of patients. So, if the patient is coming without any family history and also there is no sex difference, we can think about autosomal recessive. Other type is autosomal dominant. So, differentiate between X-linked and autosomal recessive is the test that is done is immunohistochemistry. So, in X-linked Alport syndrome, alpha 5 will be absent. So, in the epidermal basement membrane, alpha 5 will be absent. But in autosomal recessive Alport syndrome, only alpha 3 and alpha 4 is affected. So, alpha 5 is present in the epidermal basement membrane, right? So, immunohistochemistry should be your answer. But apart from this, historically, if there is no family history and if there is equal gender equally distributed in both genders, then it is autosomal recessive. Cardinal feature of Alport is hematuria. Okay. Now, ocular defects in Alports are 4 as we discussed. First one is anterior lenticonus. Second one is maculopathy. Third one is corneal endothelial vesicle or posterior polymorphous dystrophy, and fourth one is corneal ulcers. Okay, we also discussed that cataracts are seen in Alport syndrome plus leiomyomatosis. Okay, EM findings in Alport. We learned that there are 4 important EM findings in Alport, that is thickening, thinning, basket weaving and lamellation. Differentiation between Alport syndrome and thin basement membrane nephropathy. Again, it is immunohistochemistry. Okay, to differentiate the types of Alport syndrome also, which is X-linked Alport syndrome and also autosomal recessive, we need immunohistochemistry. Similarly, for Alport syndrome and thin basement membrane also we need immunohistochemistry, because in Alport syndrome, alpha 3, alpha 4, alpha 5 chains are going to be absent, but in thin basement membrane nephropathy it is going to be normal or present. Most common cause of persistent microhematuria is thin basement membrane nephropathy. Maltese cross appearance in the urine and zebra bodies in the EM is seen in Fabry's disease. Okay, the Maltese cross appearance is nothing but it is the fat globules that are seen, and zebra bodies are nothing but it is the deposition of the, it is seen in the lysosome of the visceral epithelial cells where these glycosphingolipids are accumulated. So it is alternating of this lipid layer with the normal layer. Okay, moth-eaten appearance in the glomerular basement membrane, that is seen in nail patella syndrome. Okay, so you have to know that the electron microscopy of all three diseases are important. That is, in Alport syndrome, we know that 4 important things were seen, that is thickening, thinning, basket weaving and lamellation. In Fabry's, we saw zebra bodies. Okay, and in nail patella syndrome, we saw moth-eaten appearance. Please remember this, it is very, very important. It has been asked almost every single time as an MCQ. Okay, so these electron microscopy finding of these 3 conditions, and also that immunohistochemistry is used to differentiate between the subtypes of Alport syndrome and also between Alport syndrome and thin basement membrane nephropathy. Otherwise, early in the disease, there is not much difference between Alport syndrome and thin basement membrane nephropathy. Thank you, friends.